Okay, so we're trying to cover Wilms tumor today. Now, Wilms tumor is a tumor of the kidney in the embryological developmental stage where you have the metanephric blastima, which is the mesenchymal tissue, which intermixes with the ureteric bud epithelial tissue, and these induce nephron differentiation and formation. And uh, after the differentiation and formation, failure of this reciprocal induction will leave the persistence of embryonic nest in the kidney, which these nests will then grow and form Wilms tumor. Okay. Now, in this entire uh, merging of the metanephric blasphemia with the ureteric bud, you have the WT1 gene, which is on 11p 13 chromosome, which is a transcription factor regulating nephrogenesis, and then you have the WT2 gene or the insulin-like growth factor, which is 11p15, which is imprinting control and regulation control. So the WT1 and the WT2 genes are in balance and harmony. Okay. And when there is a failure of the WT2, then there is an issue in induction. If there is a failure in WT1, there is an issue. So CTNNB1 is another gene which contributes to that, and TP53 is another gene, obviously, which will cause uncontrolled growth of the metanephric blasphemia. Now we know that the WT1 gene is on level P13, and it loss or mutation of WT1 gene or the deletion of 11p13 thing will cause the WAGR syndrome. Okay, and when the WT1 is normally expressed, metanephric mesenchyme triggers differentiation into epithelial nephron structures. The WT1 beta catenin signaling pathway, when the WT1 is active, it will activate beta catenin, which is then degraded by APC and the beta catenin degradation complex. The CTNNB activating mutation, WT1 loss, uh, can cause uncontrolled growth. Now, the main thing is not WT1 but WT2. In 11p15, WT2, which represses insulin growth factor to decrease. WT1 represses insulin growth factor, and here WT2 is the one which regulates this insulin like growth factor halt. Okay, so the actual significance here is that on 11p13 you have the WT1 gene. Okay, and on 11p15 you have the WT2 or the WT2 or insulin like growth factor regulating gene. On 16q, we know there is a tumor suppressor which is with the beta catenin degradation, and then the 1p1q uh, pathogens. So if there is loss of heterozygosity at 1p16q, there is a higher risk of relapse. But if the 1p16q loss of heterozygosity is absent, the it is good. Okay, and a 1q gain is again good because a 1q gain meaning we would have more tumor suppressors and they have lesser chance of recurrence. Okay. So gain is always better in tumor suppressor genes. And then TP53 is poor, and 11p15 methylation increases the risk of relapse. So that's why they have risk stratified Wilms tumor in that particular way. Now, Wilms tumor is studied actively by two organizations. One is the COG or the Child Oncology Group and the COP protocol, and both of them have different approaches. One of them suggests neoadjuvant treatment, and one suggests direct surgery. So now let us look at the COG staging. Stage 1 of Wilms tumor is limited to the kidney. Stage 2 is extension beyond the kidney and penetration of the renal capsule and invasion of renal sinus. Stage 3 is tumor spillage, gross microscopic residual tumor, residual lymph node, peritoneal cytology positive. Stage 4 is hematogenous mets to lung, liver, bone, brain, lymph node mets. Stage 5 is bilateral uh, Wilms tumor. Okay, so that's the staging. And if the tumor is removed piecemeal, the tumor rupture, spillage or peritoneal disease, that's stage 3. And stage 2 is extension beyond the kidney but completely resected, penetration of the renal capsule or invasion of renal sinus but completely excised. So COP is the one, and COG is the other. Um, Now, Wilms tumor is categorized into risk groups based on the COG is the upfront surgery, and COP it is more things. So you give neoadjuvant chemo, and then you do the operation, and then you evaluate the response. So if you do a direct Wilms tumor surgery, you can have a favorable histology or an unfavorable histology based on the blastema component. If there is no anaplasia, it's a favorable histology, and if there is anaplasia, it's an unfavorable histology. When you are giving neoadjuvant chemotherapy, based on that, the COP will categorize Wilms into low, intermediate, and high risk. Now, low risk is when there is a complete necrosis after neoadjuvant chemotherapy. Intermediate is if there is greater than 60% of necrosis. And in high risk is if there is a blastema predominant component and less than 66% with a greater than two-thirds of blastema component, we call it high risk. Now we will put Wilms tumor into uh, groups, okay? And based on the stage 1, 2, 3, 4, we will put them into very low risk and high risk, and standard risk and low risk and standard risk and high risk, high risk and high risk. Okay, so here stage 1, if you can see here, very low risk stage 1. What is very low risk? If it is less than 2 years of age and very small tumor of size and favorable histology, it is very low risk. If it's just a localized tumor, it is low risk. If lymph node capsule rupture, unfavorable histology is stage 3. Stage 4 is metastatic disease. Stage 5 is bilateral Wilms tumor. So if we classify this stage 1, 2, 3, 4, and 5, uh, based on the risk and everything, we have to classify Wilms tumor into these 5 stages. Now, stage 1, very low risk is nothing. We don't do anything. Stage 1, low risk is again, uh, you can remember it like stage 3, you will have 3 chemo drugs, that is vincristine, actinomycin, and doxorubicin. Stage 2 will be low risk and you'll have 2 chemo drugs, vincristine and actinomycin D. And stage 4, you will have the M protocol, which is vincristine, actinomycin, doxorubicin, the 3 drugs plus cyclophosphamide and etoposide for up to 36 weeks. Okay, that's almost 8 months. Now, stage 5 is bilateral Wilms tumor, and the key of that is we will give pre-op chemo, try to reduce the size of the tumor, and go for nephron sparing surgery. If we are talking of unfavorable histology or anaplastic, we are talking about the M protocol, which will use vincristine, actinomycin, doxorubicin, cyclophosphamide, etoposide plus RT. Now, RT is important where you will give whole lung RT if there is this mets, lung mets. And in the radiotherapy, flank radiotherapy, remember you're treating an infant, so you want to keep it as low as possible. In the intermediate risk, you're supposed to give 10.8 grade. The radiotherapy recommendations are different. So stage 1, look at the 1p16q. If these are lost, then that's an issue. If it's a gain, it's good. But if it's lost on P16Q, And then you look at the blastema component and you categorize them into very low risk, standard risk, and high risk. Anyone with high risk, which would be stage 3 with 1p16q loss, then it would automatically come into high risk. Or if the blastema component is greater than 66%, it would still be high risk. So in high risk Wilms tumor, you will do M protocol with radiation plus or minus radiation to the lung based on tumor board discussion. In very high risk one, you have increased nitromycin, cyclophosphamide, etoposide, and carbo. Very high risk two, increased nitromycin, cyclophosphamide, etoposide, carbo, and I will not take care. Okay, and that is the regimens which we manage Wilms tumor. Now, if you have bilateral Wilms tumor, we would start a three-drug therapy, reassess at 6 weeks, and then bilateral partial nephrectomy and partial nephrectomy. If we are doing surgery, if we are doing partial nephrectomy, it's not possible. If partial nephrectomy is possible, do partial nephrectomy after neoadjuvant. If partial nephrectomy is not possible, see if there's greater than 50% reduction or less than 50% reduction. If there's less than 50% reduction, you do an open biopsy. But if there's greater than 50% reduction, you continue three-drug regimen and then you do surgery. After surgery, you look at the you go back to the SIOP protocol. Okay, and based on the COG group, you will do EE4A, DD4A, regimen 1 or regimen M. So look at the blastema component, look at the risk component, and then decide what treatment you want to give. So to recap, Wilms tumor is a tumor of the kidney, and you put him into stage 1, 2, 3, 4, 5. If they have any high risk features, put them in stage 3, 4. If you look at the blastema component, look at the epithelial component and the mesenchymal component. In stage 1 and 2, you can do upfront surgery, write in the answer based on the COG or COP protocol, which one you are quoting. Look at the COP necrosis, and then you give the risk categorization, and then you do the prognosis. If the necrosis is less than 66%, 66 to 90 and 100%, 100 is very good. So that would be low risk, 60 to 99 would be intermediate, less than 66 would be poor risk. In the COP neoadjuvant protocol, in the COG protocol, we are doing upfront surgery, looking at the histology favorable or unfavorable and deciding which regimen. If it is favorable or unfavorable, in favorable you can give EE4. If it is unfavorable or DD4, or you give the M protocol in extremely high risk and unfavorable COG. M protocol is using for more drugs. So stage 1 is one modality, stage 2 is actinomycin and 7%. Stage 3 is 3 drugs, stage 4 is at least 4 drugs. Stage 5 is neoadjuvant, remaining surgery and adjuvant treatment. So if you have to recall the mutations and the risk staging, if you look at favorable histology in stage 1 and 2, look at last heterozygosity at 1p16q. Okay, and know that the WT1 gene is on 11p15, and if 11p15 WT2 is gained, then it's a good sign. So 11p15 methylation is the inhibitory complex for the insulin-like growth factor regulation. So remember WT1 and WT2. WT1 causes the epithelial mesenchymal transformation, and WT2 causes the insulin-like growth factor imprinting, and loss of imprinting and overexpression causes abnormality. So no WT1, WT2, CTNNB, TP53, and WTX. Then do the molecular classification. If there is the 1p16q gain is 3 to 4 times risk of relapse, it's absent. And look at 1q gain, which is favorable. Look at TP53 mutation and look at 11p15 methylation. So WT1 loss, insulin-like growth factor to overexpression, loss of heterozygosity 1p68q, mutation of TP53, and segmental 1q gain. So if you have 1q gain, then it is beneficial. Okay. And this WT2 is located at this 11p13, 11p15. So that's how you will approach Wilms tumor, and you will decide the M regimen, 3-drug regimen, 4-drug regimen, and bilateral Wilms tumor. You will try to obtain further cytoreduction, and then you will manage it. Thank you.